our last one, as I step down as dean, I think what you most what is most important is really the people you've been able to recruit to lead programs at the University of Rochester. And I think one of the things that I am happiest is with the ability to have recruited recently Lainie Rose, who really will give you some idea of what the biopsychosocial model looks like and how we expand this in the future. Dr. Ross got her AB from the School of Public and International Affairs at Princeton, her MD from the University of Pennsylvania, a PhD in philosophy from Yale, and then trained at Children's Hospital of Philadelphia and at Babies Hospital of Columbia University. For many years, she has been at the University of Chicago, where she was a leader of the Clinical Translational Science Institute, and where she really developed an international reputation as really one of the leading bioethicists in the country. One of the reasons we were able to recruit her was our desire to really build a department of health humanities and bioethics. There are very few in the country, but we thought that this is right for the University of Rochester. So she is the Dean's Professor and inaugural chair of that department, and the director of the Paul M. Scheibe Center for Bioethics at the university. So please welcome Dr. Lainie Rose.
Thank you for that very warm welcome, and proud to be a newest member of the University of Rochester. And yes, so today I want to talk about reimagining the biopsychosocial framework at the core of the Department of Health Humanities and Bioethics. So I want to give a little bit of history of how we got to become a department. So it goes back to 1977 and the publication by George Engel of the need for a new medical model, a challenge for biomedicine. And most of us know what that was about. He was arguing against the reductionist approach to medicine, where all we were looking about was the disease. And instead, he said, we need to start with the patient as person. Then we can drill down and look at the pathophysiology and the genetics, but we need to start with the person. And then we need to go up and look at the person as a member of a family, the member of a community, the environmental impact, the biopsychosocial model. Within a few years, the dean at the time decided to create a division of medical humanities. Again, one of the first in the country. And Catherine Montgomery became its first director. She was actually a PhD in English, and she wrote a book called Doctor's Stories, which really is a precursor to narrative medicine, very popular now here, but wasn't at the time. In 1991, the program expanded to include bioethics. We brought in Jane Greenlaw, who would become the second director. She was trained as a lawyer and as a nurse, and she also started a clinical ethics program. And we've had clinical ethics consultation here for over 30 years, 24/7. 2014, through the generosity of Paul Scheibe, we created the Center for Bioethics, in addition to the division. And the center has actually three missions. One is to have clinical ethics, not just here at Strong and at Golisano, but throughout the entire Rochester health systems. The second is regionalization, to have bioethics and health humanities across Western New York. And the third is beyond the medical centers, to go into the community and to bring bioethics in order to regain the trust that we need in order to take care of patients appropriately and to fully get them to improve their health outcomes. 7 years later, we're now in the middle of the COVID pandemic. And in fact, partially that forced us also to be thinking regionally, because bioethics were thinking about allocation of resources at the time. But it was that, and in the aftermath of George Floyd, it became clear to Dr. Taubman that they needed to change from a division into a department. Stephanie Brown-Clark, who had been here as the third director, became the interim chair until I arrived in January. So I want to really thank Mark for being visionary as one of only 8 departments across the country that are departments of health humanities and bioethics. So I want to show you right now how health humanities and bioethics is already integrated into all three academic missions. And then I'm going to talk about where I want to take us. So first of all, in clinical care, I've already talked about our clinical ethics consultation service. We actually offer health humanities also in the clinical setting. We have art at the bedside, we have music programs, and in fact, we have a program called EPAM, the Eastman Performing Arts and Medicine, which is a program between the Eastman School of Music and our department. In education and training, just as when you were here, the biopsychosocial model is one of the most important learning objectives. Goal 1 reads, embody the biopsychosocial model by integrating the foundational scientific knowledge of medicine with the personal and cultural aspects of the patient in providing individualized education and care. There's a new curriculum, as I'm sure if I look through all the different classes, there's always new curriculums coming through, but currently health humanities and bioethics is embedded across all 4 years in all courses. We're less of an individual course, but instead in every single course that the medical students take, there's some aspect of health humanities and bioethics. So if you look at your anatomy class, you're gonna have lunch, listen, and learn. You're gonna actually start with a course, a lecture on, see, not even a lecture, really a participation, going to the art museum and looking at art as observation. Then you're going to go into your neurology class. You're going to talk about defining and determining death. You're going to do it even through all your clinical years. In the new curriculum, not only are we embedded in all of those courses, but the biopsychosocial model is part of every single one of our learning objectives. The most important change from going from a division to a department is the addition of research and scholarship, and that's what's going to be new. And there are two ways of thinking about research and scholarship in health humanities and bioethics. One is to think about it as a silo. So I can write books about philosophy of medicine, but more important and more enriching is to embed our health humanities and bioethics into translational research. So as I always say, I want to see bioethics, health humanities, and as well as equity and inclusion as 3 threads in a braid that are going to go across the entire clinical and translational research spectrum. So what I want to do now is give an example of health humanities and bioethics embedded into translational research. And I'm going to give an example that I just completed, which I call Think Zebras, Not Horses, Atypical Diabetes Mellitus. So just a quick reminder about diabetes, 90 to 95% is type 2 diabetes, 5 to 10% is type 1 diabetes, and less than 1% are these other two. There's atypical diabetes, also known as monogenic diabetes. There's neonatal diabetes, which is often autosomal recessive. And then there's maturity onset diabetes of the young, which has many components of it are actually autosomal dominant genetic causes. And then there's gestational diabetes, which sometimes is actually a manifestation of one of these MODY mutations. So I'm going to focus then on the monogenic diabetes. So MODY classically presents as non-influenced, non-insulin requiring diabetes in lean individuals less than 25. So you hear lean individuals, you're thinking type 1, but it's autoantibody negative, so they're often thought to be type 2. And in fact, approximately 95% of individuals who have MODY are misclassified. They're diagnosed as having diabetes, but they, depending on their doctor and depending on the year, they'll be called a type 1, a type 2. Some of our participants in this research study said sometimes they were just called 1.5. There are 3 most common forms: HNF4 alpha, GCK, and HNF1 alpha. And I'm a general pediatrician. I am not an endocrinologist. I'm not going to give you all the details. What I'm going to tell you is the most important thing is to avoid insulin. But you don't avoid insulin unless you know that you're dealing with a MODY type of diabetes. So here's the study we did. It was a qualitative exploration of participant challenges in the monogenic diabetes registry. And at the time of the study, the monogenic diabetes registry had about 4,400 individuals, and only about a quarter actually had a known genetic cause. So there's a lot of room for that biopsychosocial model to dig deep to try to find the genetic explanations. In our sample at the time, or what we could recruit from, there were 499 probands, including 333 relatives from 200 unique families. And so the number of families in the registry, there would be members ranging from 1 family member to 7, but only 42% had at least 1 other member. And that's a real opportunity lost, because if you have autosomal dominant, it means one of the parents has it. It means there's a 50% chance that every sibling has it. And it means there's a 50% chance that the proband's children have it. And so from an efficiency perspective, you really want to be looking at the rest of that family. So I became part of an R01. I took on what I call the third aim, which is where I often think bioethics finds itself. And what we asked were, what were the obstacles faced by an individual to enroll in the registry? And what were the obstacles to enroll family members into the registry? So our methods were qualitative interviews. Then we did thematic analysis, having developed a code tree using Atlas TI. And irrelevant to details, I know you can't see them. I'll tell you the important things. One is that we had 20 individuals, half male, half female. They range from the ages of 20 to 80s. We actually give very little demographic information because these are rare diseases, and these individuals could be easily identified just by the amount of information that I might have put onto this table. The most important thing is, though, is to look at that thick column, which says prescribed medications. And what you see is how many of them were being mistreated, sometimes for years, sometimes for decades. And so in our interviews with these individuals, we came down with 6 primary themes. And I'm just going to focus on 2 of them for today. I want to look at the medical odyssey, and I want to look at the disclosure experience. And I want to start with the medical odyssey and say that it was often the patient who initiated the identification that they actually had an atypical diabetes. It was not the clinician. And so you're not going to be surprised that of the 20, all of them had a college education, and most of them actually had either a master's or a doctorate degree. And why? And that's going to lead to healthcare disparities unless we can figure out a way of getting us, the clinicians, to be looking for more MODY cases. So why did they have to be so, in a sense, so highly educated? They had to be not only highly educated, but also really empowered to be able to question their doctors and the diagnosis that they had been given. So here's one who says, they claim I'm type 1. I usually fall into the typical type 1, and they start with insulin. But after a couple of years, my antibody was always negative. I feel I'm just very atypical. So I kind of read more about diabetes in general, and I read of this form of MODY. The more I read, the more I feel, hey, that sounds like me. Or another participant said, I started with Google, but then it went deeper. I went and found some of the different medical articles that were listing the different types, what the gene modifications were like, what the medication recommendations were, and what the long-term consequences or whatever long-term outcomes were. Some of them had higher rates of eye disease, and some of them had rates similar to the general population. So a very empowered group of patients. But when they told it to their docs, when they went through our registry and got the information, they found the physician as obstacle. First of all, going to your GP, convincing them that you deserve, a referral to an endocrinologist who's going to book you out based on your hemoglobin A1C a year from when you get your appointment, which is what happened to me. Another said, my doctor had never thought about it, never heard about it. After she received the results, she was like, oh yeah, you have MODY. She looks me right in the eye and she goes, so tell me why I should care. And I looked at her like, because you've been trying to help me take a drug for years that I don't need to take. If we think the physician was an obstacle, wait till you hear how their families responded, because they then became the messenger and tried to convince their family members, you may be being mistreated because you've been misclassified. And they understood the importance of cascade testing. So here's what one of the participants said. So actually, I'm feeling frustrated when I do tell them this and they don't know what to do with it, and they don't. They're not researching or even taking it serious. We have it pretty much narrowed down to my dad's side. The relationship with me, with all of them, is a little strained. I do plan to, and they were so good about giving me information when I was collecting it to get into the study, that I do feel like with them, it's just so hard for me. Another participant said, there's diabetes in my family. So when I called my brother to say I found this diagnosis, and I think most likely we probably all have this MODY, he was like, well, no, my doctor already told me what I have. And he was just resistant to hear any more information. So what can we learn from this? I think what it points out to is the importance of the biopsychosocial model, right? So the researchers that I was working with were looking for the genetic causes. I was trying to help this project go beyond that, and then to look at the patient as person and to take it to the biopsychosocial model. right? So I needed to figure out both that zebras aren't horses and that we have to get beyond our diagnostic complacency. But we also need to understand when a patient says that they're being compliant, they are sometimes, and sometimes they're not, but we need to be hearing them, because when these patients would go into their doctors and their hemoglobin A1C was going up, rather than thinking maybe you're on the wrong medicine, they were being told you're not adherent to the plan. And so we need to be understanding the psychological, the social, in order to be able to help these patients. I've taken this model of embedding ethics into research here already. Having come here, we applied for 2 grants, 2 supplements to NIH grants the week that I got here, and both of them were successful. One is I'm working actually with Parkinson's disease patients. We're looking at a study with Kluger on patient-reported outcomes. We're also, and we're asking, so patient-reported outcomes, the plan is to return it to the patient. What does the patient do with that information? And so one concern is if they're bringing it to their primary care docs who are already feeling overwhelmed, are we going to be increasing, in a sense, the burnout that they feel? And then what responsibility do we have to ensure that they understand the information from that research and not putting the burden onto the community members? And then I'm also doing a project with the CTSI, but I'll describe more if we have time in the questions. Thank you very much, and I'm happy to be here.
Thank you very much, and I always appreciate this perspective. But my question is, how does it actually trickle down to the 15-minute appointment that one actually has with their physician?
That is, you hit it on the spot. I mean, so one of the things, so I'm a general clinician, so I actually have the advantage of getting to know people longitudinally over time. And actually, if you look at George Engel's work, he actually talked about that part of the beginning of a 15-minute appointment was to negotiate what aspects of your care are we going to focus on today, because we're not going to be able to cover the whole thing. I think it's right. I also do think it says the whole thing when that's, in a sense, you've hit the really the third rail. That's a problem with our healthcare system, right? But we still need to figure out a way of incorporating the biopsychosocial, and it may be that we just need to think about it longitudinally.
I have a comment and a, excuse me, and a question. I know George left, he and I trained together, so I've talked to him a lot, but what we talked about today is what makes me proud to be an alumnus of this school. And I think this is the kind of stuff that U of R is all about. My question, I'm at Griffin, which is the Center for Plaintree, and our Plaintree concepts, we've worked with the Netter School, as you have here, to get it part of the curriculum, but we've also struggled, I think, with indoctrinating the residents, just because of the limitations there with their schedules and requirements and all. What have you done here? What are you trying to do here to get this at a resident level? Because obviously that's where we're going to get them to carry this further and into the community.
Thank you. 2 things we're doing. So the first thing is through our clinical ethics program, for example, we meet monthly with the NICU. So instead of them coming to us, we go to the NICU so that therefore we can work with not just the residents, but the attendings as well as the nurse and all the other staff. We go there monthly. I've started a relationship with the PICU where we're going quarterly. We have one every quarter. We also meet with the medical residents. And if I could clone myself, we'd be doing that in every single department, but I'm looking to hire, and we will be doing that in every single department through residency training. The other thing we're creating is a certificate program where, so one of the things that I'm sort of adapting and adopting from when I was at the University of Chicago, we offered a clinical ethics fellowship where you could do, when you were doing, for example, a cardiology fellowship, you could combine, you could do a 1-year part-time ethics fellowship and then do your research, which would combine your cardiology and your ethics, or really what it would be combining here is your cardiology into the biopsychosocial model. It'll be very easy. At UChicago, we had the surgical residents who have 2 years of time in the basic science, that they could come and do 1 year of this certificate as well in order to get that sort of training. And I've actually spoken to the chair of surgery about doing this here as well. So these are the type of ways that we want to bring it into the residents. But you really have to not just do it with the residents, you also have to go top down, because otherwise, if the residents get onto the wards and their attendings aren't talking biopsychosocial, they're going to forget it. So we're trying to create programs as well for faculty, as well as from the medical students. So we're going top down and bottom up approach. Thank you.
on, I think then we gotta move on.
George Engel was a great hero to many of us in medical school here. We knew him well and appreciate him. Thank you for continuing his legacy. I'm fascinated by the very last comment you made, your consideration for the primary care physician who is overwhelmed. We have a major problem in the city and this nation with physicians who are burning out, and we can't find primary care doctors to take care of many of our patients. And those of us who are specialists, I'm a cardiologist here, are being asked to substitute in areas that we're not used to practicing. So ethical consideration of what the needs and opportunities are for primary care physicians, I think, is an important opportunity.
I totally agree. Thank you very much.